Nat asked me to speak on anesthesia and bloodless obstetric surgery, so that's going to be my focus is the anesthesia care in a bloodless obstetric patient. So I'm going to hopefully use a number of case examples to illustrate how I go about approaching these particular patients. But before I start, this is where I'm speaking from. It's in Pennsylvania, in the city of Pittsburg. And this is the city of Pittsburg at the point, which is where the two rivers, the Allegheny River and the Monongahela, come together. And I've put a star where the Jehovah's Witness Church was founded. It's on the north side in what used to be called Allegheny City. It's near Heinz Field, which is our football stadium. And there's a plaque at the location where Charles Taze Russell founded the Jehovah's Witness Church. So we have a fairly high concentration of Jehovah's Witnesses in this region. And they've been mismanaged for probably the last 20 years until we formed our bloodless medicine program. At this point, we see about 1,600 Jehovah's Witnesses come through our doors, with about 25 of them achieving what I call severe anemias, meaning less than 5 grams per deciliter of hemoglobin. Just to get started, there is a great website, jw.org, that has some information for clinicians. It's a fairly extensive amount of information, so if you're looking for hints on how to care for these patients, this is the place to start. Now, one of the pages in this website is shown here, where it highlights what most Jehovah's Witnesses, or at least all Jehovah's Witnesses, will refuse, which is the main components of blood: red cells, white cells, platelets, and plasma. But there is also potentially acceptable products, and these are things that need to be discussed with every patient individually. And these are particularly important products, especially fibrinogen, which can be attained either through fibrinogen concentrate or through cryoprecipitate. And then there's also blood salvage, as Carolyn alluded to. Autotransfusion or blood salvage is kind of my baby. I think it's one of the most adaptable strategies for taking care of these patients. To illustrate this, this is a Jehovah's Witness that we cared for about a year ago. She presented at 35 weeks gestation with an IUFD, or intrauterine fetal demise from a placental abruption. And as an OB anesthesiologist, this is one of the most feared presentations because of the coagulopathy that develops with one of these abruptions. This particular patient, her INR natored at 15.3, which is pretty much unheard of. Her platelet count natored at 100,000. Her hemoglobin natored around 3. She was a patient that we ended up giving Hemopure to because of that low hemoglobin. A D&E was performed, and bleeding was treated with multiple factors: 4-factor PCCs, tranexamic acid, vitamin K, and 85 units of fibrinogen concentrate. And subsequently, her INR normalized to 1.3, and she was subsequently discharged home on post-op day number 5. So this kind of illustrates the importance of fibrinogen to the care of these patients. And I think what you can do is you can surpass low platelet counts by kind of hyper concentrating the fibrinogen concentration. So if a patient is agreeable to fibrinogen concentrates, it's something that should definitely be considered. Now, there's a website that was developed by the California Maternal Quality Care Collaborative, as is shown here. And there is a series of steps that they recommend that you take when managing one of these obstetrical hemorrhage patients. And the first thing, and this is the resource link where you can find it. But the first thing that they recommend is that you stratify patients for risk of bleeding. And this is what they recommend you do. Now, for a Jehovah's Witness patient, it's a waste of time to type in screen and type in cross-match a patient. But I think it's important to identify patients who are at high risk of bleeding during the course of their care. And we've done some mathematical modeling on our database, which contains about 80,000 patients in it. And these are in bold the areas where we found there was the most risk for hemorrhage during the course of delivery. And unfortunately, singleton pregnancy was the greatest risk of bleeding. And I think these are because they labor for 2 days, develop chorioamnionitis, become refractory to Pitocin. So it's really kind of a crapshoot as to who is going to bleed. Some of the other things that they recommend is that you should transfuse 2 units per clinical signs. Now, I got a real problem with this, regardless of whether or not it's a Jehovah's Witness. I think that the patient should be transfused based on clinical presentation and laboratory values. Other things that they recommend is establishing IV access. And this is something that we have run across in patients that have been life flighted into our hospital, is they oftentimes come with a 22 gauge IV hanging out of their arm with very little opportunity to get additional IV access because they're so hypovolemic. So we've started using intraosseous drills to a larger degree because you can put one of these lines into a patient in about 3 seconds, and it runs like a 16 gauge IV. So you can resuscitate somebody very, very rapidly with an intraosseous line. Stage 3 in the CMQCC recommendations is making sure that you aggressively treat the patient with uterotonics. One of the things that I have problems with is the use of hemabate. It's oftentimes avoided in patients that have histories of asthma or bronchospasm. And I think you need to really balance, the benefit of hemabate in this particular environment. I mean, we have lots of treatments for bronchospasm, and it's growing by the day in terms of the numbers of drugs that we can use. Whereas hemorrhage has an ultimate end, which is not good. So if you need to use this particular drug, I say go for it. Blood products, there is a recommendation within the CMQCC to use the 1:1:1 ratio. I'm a massive opponent of this particular strategy. I think it should all be laboratory guided. And there's some work that Jeannie Callum published out of Canada where she showed that laboratory-based transfusion led to significantly better outcomes than the 1:1:1 transfusion strategy. Now, granted, this is not something that you would be exposing a Jehovah's Witness to, but it is something to keep in mind for other patients. So the next patient I'm going to present is a Jehovah's Witness who presented for an elective cesarean section to our hospital. She had a previous delivery where she had a significant bleed, and she presented to our operating room with a hemoglobin of 9.6, which is problematic. The World Health Organization defines anemia for a pregnant patient as anything less than 11. So this patient was clearly anemic. She had autotransfusion or cell salvage implemented during the course of her surgery, but her uterus became atonic. She ended up with a hysterectomy and then was transported to the ICU where she became unstable, at which point we opened her at the ICU bedside where a pedicle bleed was noted and tied off. And her nadir hemoglobin was 1.7. Um, and this really illustrates how tolerant the pregnant woman is of severe anemias. And I don't think we have good data as to what the endpoint is. But this particular individual did extremely well. On post-op day 1, she looked so good that she was extubated. And when I went to see her in the late afternoon after her surgery, she was playing with her kids in the hospital bed, saying that she was a little tired. And at this point, her hemoglobin was 2.7. So I think the obstetrical patient is fairly tolerant. And if you think about it, nature probably has designed the pregnant woman to be tolerant of severe anemias because it's something that they would face without modern healthcare. So antepartum anemia management is something that I think should be a focus of any obstetrical unit, what this means is we treat iron deficiency. And this is a slide of some data that was collected that shows, the iron stores, during the course of gestation. And you can see they shrink to about 20% normal during the course of the 3 trimesters. So I think we underutilize iron supplementation. And in fact, it's more the patient preferences. They don't like to take iron. Erythropoietin is probably a waste of time in most obstetrical patients because erythropoietin concentrations go up, as is illustrated by this work. But I think the vast majority of anemia in pregnancy relates to iron. And this is something that's very cheaply treated. This is a bottle of iron from a local pharmacy. And the cost of iron is about 2 cents per 65 milligrams. So as a first line therapy for iron deficiency, this should be it. Now, Manuel Munoz in Spain has published this work where he looked at the cost of intravenous iron. And I think we way underutilize intravenous iron. And there is a general fear of cost and a general fear of anaphylaxis. And I think both are unreasonable fears. As you can see, the costs of the particular iron molecules is cheap. And there's almost no anaphylaxis that occurs with the modern molecules. If you compare this to red cells, $225 for the average unit of red cells in the United States versus $10 for a dose of IV iron, it's a no-brainer in terms of the economics. So one of the things that was seen with the patient that I mentioned just a moment ago was the patient went from a hemoglobin of 1.7 to 2.7 within 24 hours. And you can see from this graph of patient blood volume, what happens immediately after delivery is there's a rapid concentration that takes place. And this basically corrects many anemias that develop during the course of delivery, or rather gestation, is that there is about a 3-day period of time where there's a hemoconcentration that can correct many anemias, at least relative to our laboratory values. So one of the things that we've done in our hospital is we've developed a checklist for both the obstetricians and for the anesthesiologists. This is a checklist that we use for our anesthesia providers. And one of the things that we have identified as being important is aortic cross-clamping, which is something that's kind of been lost in the obstetrical world. But there's a newer device called the REBOA, or the retrograde endovascular balloon occlusion of the aorta. And this is a device that can be floated up through the iliac artery up above the uterine arteries to stop blood flow while control is obtained of that blood loss. Other things, monitoring of hemoglobins and thromboelastographs during the course of care will optimize the management of the patient's hemoglobin and their coagulation function. And some of the devices that we use, this is a thromboelastograph, the newest generation. It's called the TEG 6S. And it gives you 4 different tracings, one of which is a fibrinogen concentration. If you look at the lower corner, which is highlighted in yellow, that's the fibrinogen concentration for this particular patient that was bleeding. You can see it's super normal, which is typical of pregnancy. At 633, a normal patient would have a fibrinogen level of 200. So we want to keep this fibrinogen level up, which highlights the importance of fibrinogen transfusion or fibrinogen concentrates. Other things, HemoQ use, hemoglobin measurement during the course of care can be important, perhaps not in the Jehovah's Witness patient, but in the regular patient. And HemoQ takes 20 microliters of blood to fill up this cuvette on the right side in order to get a hemoglobin concentration. And I think this can guide red cell transfusion. So moving on, this is a patient that I took care of when I was at the Cleveland Clinic, which was 18 years ago. This was a non-Jehovah's Witness patient who presented with vaginal bleeding to our labor suite. I believe she was 30 some odd weeks pregnant, but anyway, she presented with a hemoglobin concentration of 6.8, a blood pressure of 57/17, and a fetal bradycardia. So general anesthesia was induced and maintained with propofol, and the importance of this is that general anesthesia should avoid our inhalational agents because they all relax the uterus, which leads to increased bleeding. So we now basically manage all of our general anesthetics with propofol administration. And this just highlights this particular thought or concept. So in managing this particular non-Jehovah's Witness, we called the blood bank asking them to send us some red cells. But upon delivery of the placenta, it was discovered that she had a placenta accreta. Initially, it was thought she had a vasa previa. And this particular placenta accreta happened to be right under her symphysis pubis, so it was very hard to reach. One of the other things about this particular patient is that she had been transfused previously during the course of an auto accident. So she had multiple antibodies, and the blood bank basically said, we got nothing that is compatible for this particular patient. So we implemented autotransfusion, and that this was at a time where autotransfusion was considered contraindicated in the obstetrical patient. A hysterectomy was performed, and we were able to scavenge 3 units of cell salvage blood, and she left the operating room with a hemoglobin of 5.1. And this is how she did clinically post-delivery, is that she hemoconcentrated, as I mentioned, and she was discharged on post-op day 4, which is typically 1 to 2 days longer than a normal post-cesarean section, but she received no blood products during the course of her care, despite her nadir hemoglobin. So this kind of highlights why I'm a big fan of autotransfusion, is that it gives you flexibility to take care of patients that present with unrecognized or unpredicted blood loss, is that you can implement this particular strategy very rapidly, and you can provide large quantities of blood. And my own personal record is 279 units of blood for a particular patient, not an OB patient, but a patient that suffered from an aortic aneurysm rupture. But the use of autotransfusion in postpartum hemorrhage was first discussed by William Highmore in 1874, where he observed a woman bleed to death following a delivery. And he thought, gosh, all that blood that's in her bed, perhaps it could be collected and used for resuscitation. So this was the main way that patients were resuscitated for about 70 years. And this is a case report from 1834 or 1934, reporting on ectopic pregnancies and the use of, this is non-washed autotransfusion or cell salvage blood. There is a company called Sisu Global that has been marketing a device that looks like a giant syringe, is being shown here, where you suck blood out of the patient, you pump it into a blood bank, as is shown on the left side of the slide in the lower corner. And then this unit of blood is basically hung and reinfused. And again, this is unwashed blood. So, for a resource limited environment, I think we can go back to the era of unwashed blood and dumb it down a little bit, because patients tend to fairly well tolerate this unwashed blood. And this was recognized back in 1974, where this Bentley autotransfusion device was developed. And the whole goal of this was to collect unwashed blood in this reservoir that looks like a sphere on the top of the machine, and to basically pump it back into the patient. The only problem was that there was no fail-safe mechanism when the sphere ran out of blood, so it would pump air into the patient. So this device led to air emboli, and so was quickly taken off the market. Now we have these washing devices, and this is the list of devices that are available. And there's some misinformation that's available or circulated about the need for a continuous circuit when caring for a patient with autotransfusion. And this is a case report that highlights this misinformation about how this particular patient was agreeing to bypass, but was against a discontinuous circuit with a cell salvage device. And these particular devices all do batch processing, meaning they process batches of blood, whereas the CATS device does continuous processing. So I think it's been a marketing ploy for the CATS to advocate for this continuous circuit, because they're the only device on the market. And this is how you do it, and I'm going to just skip through this. This will be available online. But this is something that's I've investigated with the Watchtower as the need for this continuous circuit. And what they tell me is that there is no doctrine that requires a continuous circuit, in that this is basically something that's left to the conscience of the individual as to whether or not they believe this circuit is an extension of themselves. And generally, when a patient requires this, it's significantly more difficult to provide this care. And we usually bring in our lay liaisons to talk to patients about this when they require it or demand it. So this is some of the contraindications historically associated with autotransfusion, one of them being use of in obstetric surgery. And I'm going to quickly flip through this just because I think we're time limited. But this is a collection of case studies that was composed by Giancarlo Liambruno in Italy, where he identified 1,665 cases of autotransfusion being performed in obstetrics with no adverse outcomes. So moving on, I don't think we'll ever prove safety, but I think we can rely on those 1,665 cases as being good evidence that it's safe. But in order to prove safety, you would need to power a study with 1.7 million subjects in order to have an error rate that was low enough that you could prove that it was appropriate. But what we need to do really is look at surrogate measures of safety, and these are some of the surrogate measures that I've looked at is biochemical washout, cellular contaminant washout, and bacterial contaminant washout. And again, I'm going to skip through this just because of time limitations. This particular filter will remove all particulates. And this is some slides of what we've demonstrated. And this is a slide of 33 patients that we looked at a number of different contaminants in cell salvage blood. And we found that following a wash and following the filtration, we could provide a product that was equivalent to what's actually circulating in the mom. Bacterial contaminants is an interesting area that I think is worth addressing. We contaminated a number of different units of blood with the bacteria shown on the far left, E. coli, Staph aureus, Pseudomonas, and Bacteroides, and found that we could remove, with the washing and the filtration process, almost 100% of these particular bacteria with this processing. Which forces you to think about the alternative, which is blood from the blood bank. And this is work published by Rosalind Yamtovian in Cleveland, where she found that platelets that were transfused were also contaminated with bacteria. So these small degrees of bacterial contamination probably have no clinical significance. So as Carolyn alluded to, we have started doing cell salvage in vaginal deliveries, and we've been using this device, the HemoSaver, which we've parked in all of our labor suites or our labor rooms, where we can implement the collection of lost blood at a moment's notice. And the blood from this particular collection reservoir can easily be moved into an autotransfusion device for washing and filtration. So because of the safety that's been shown, there are now a number of organizations that recommend the use of autotransfusion in obstetrics, and these are some of the organizations, most prominently in the UK, as well as the California Maternal Quality Care Collaborative, which is pretty much the biggest organization in the United States that recommends safety measures in obstetrics for our patients. So just a couple things to make salvage effective in this environment. Most importantly is regulation of suction. It should be down-regulated as much as possible because suction pressure will damage the red cells. And then rinsing of lap sponges is critical. This is a lap sponge that's fully soaked with blood. With rinsing, we can remove about 95% of those red cells and then suck it into our collection reservoir and process it. And we've done some work where we've demonstrated that we can remove 95% of the red cells from a lap sponge, which is significant. There are some other things I just wanted to touch upon. Iron deficiency anemia. These are all things that should be focused on in the postpartum period. The reason is that the consequences of iron deficiency in the postpartum period are significant, is illustrated by this table, where we see work efficiency, fatigue being reduced for that particular individual. And when you're trying to take care of a newborn, having your work efficiency being impaired is particularly impactful.